All right, let's step inside the operating room and explore the high-stakes world of biliary surgery. This is a field where a single millimeter can be the difference between a routine success and a life-altering complication. We're going to see how surgeons create these incredibly precise roadmaps to navigate everything from accidental injuries to aggressive cancers. So what does happen when one of the most common surgeries on the planet goes wrong? I mean, think about it. Gallbladder removal is an incredibly routine procedure. You probably know someone who's had it done. But in those rare cases when something goes sideways, when that intricate network of tubes draining the liver gets damaged, well, that's a surgeon's worst nightmare. And their response has to be immediate and laser-focused. And that's exactly what we're digging into. While millions of these procedures go off without a hitch, that small risk of a complication means every single surgical team has to be prepared. They don't just react, they follow a clear playbook. It's all about having a system, a shared language to make sense of the chaos and turn a potential catastrophe into a manageable problem. Okay, so where does a system like that even begin? Well, it starts with a map. You can't fix anything if you don't know the extent of the damage, right? And in biliary surgery, that map has a very specific name. And this is it, the Strasbourg-Bismuth classification. Now, what's so critical to understand here is that this isn't just some chart in a textbook. It's a vital, on-the-ground communication tool. It allows a surgeon in one part of the world to describe a bile duct injury to another surgeon thousands of miles away with perfect clarity. It gives everyone the same playbook. It literally brings order to chaos. Let's break it down. First up, we have a type A injury. As you can see right there in the image, this is like a small leak from a side pipe, usually the little duct where the gallbladder used to be attached. The best way to think of it is a dripping faucet. The fix is often pretty slick and minimally invasive. They use a procedure called an ERCP, which is basically a flexible camera passed through the mouth to place a small tube called a stent and seal the leak from the inside. Next up is type B. Now this is a totally different ballgame. It's not a leak, it's a blockage. A major branch of the biliary tree has been accidentally clipped shut. That means an entire section of the liver is now dammed up, unable to drain bile. What's interesting is this doesn't always require another immediate operation, but you can imagine it can lead to some really serious infections down the road. A type C injury also involves a major duct, but, and this is the crucial difference, instead of being blocked, it's been cut. So now you've got an open leak from a major pipeline spilling bile right into the abdomen. As you can guess, that is a way more urgent problem than the blockage in a type B. You know, injuries aren't always these clean, complete cuts. Take a type D. This is what's known as a lateral injury. Think of it like a burn or a gash on the side of the main bile duct. A lot of times this is caused by the heat from a surgical cautery tool. This creates a partial leak. So the duct isn't completely severed, but it can still lead to some very serious complications and scarring. And this slide right here, this brilliantly illustrates why location is everything. Both of these are type B injuries, which are the most severe, involving the main bile duct. But look at the difference. On the left, an E2 injury is a cut below the point where the duct splits into two. That's serious. But on the right, an E4 is a cut at the split, separating the right and left ducts from each other entirely. The complexity of that repair just skyrockets. Any of these type E injuries are going to require major reconstructive surgery. We're talking about essentially replumbing the liver's entire drainage system. Okay, so once the surgeons have their map and they know exactly what they're dealing with, how do they actually fix the problem? Let's get into their management strategies. Now, if an injury is discovered days after the first surgery, it's a full-blown emergency. And this is the immediate action plan. First things first, control the leak and drain any fluid that's collected. At the same time, get control of any infection or sepsis with powerful IV antibiotics. And only then, once the patient is stabilized, can you get crystal clear pictures of the biliary tree to confirm the exact nature of the injury before planning the definitive repair. And this is where it all comes together. You can see how that classification map we talked about directly dictates the treatment plan. A simple type A gets a stent. A complex type E always requires that major replumbing surgery. This methodical approach is what turns a crisis into a solvable problem. It's about ensuring the right repair for the right injury, every single time. All right, now we're going to make a big pivot. So far, we've been talking about accidental damage, stuff happening from the outside. But what happens when the threat is coming from within the system itself? Let's talk about biliary cancer. So who's most at risk? Well, the sources point to a few factors, like being female or getting older. But notice the common thread here. Gallstones, primary sclerosing cholangitis, which causes inflammation and scarring of the ducts. Many of these risks are linked to one thing: long-term chronic inflammation. It's like that constant irritation over years and years can eventually cause some cells to turn cancerous. And here's what makes this disease so insidious. It is a silent attacker. In its early, most treatable stages, it rarely causes any symptoms at all. And because of this, the diagnosis is often a complete surprise, an incidental finding by a pathologist who's just looking at a gallbladder that was removed for what everybody thought was simple gallstone disease. Cancer can also start in the bile ducts themselves. That's a condition called cholangiocarcinoma. And just like with injuries, that rule comes back. Location is everything. Cancers high up near the liver often require removing part of the liver itself. But cancers that are low down near the pancreas require a massive operation called a pancreaticoduodenectomy, or a Whipple procedure, where parts of the pancreas, stomach, and small intestine are all removed. So when cancer is the diagnosis, what's the battle plan? Well, it all comes down to staging. Staging is what tells surgeons exactly how far the cancer has spread, and that is what determines what treatments are even possible. Let's start with the earliest possible stage, T1A. This is the best-case scenario in a bad situation. At this point, the tumor is confined to just the innermost lining of the gallbladder. It is not broken through any of the deeper layers. And the good news for a T1A tumor is that the simple gallbladder removal surgery might be all the treatment that's needed. If the cancer is discovered after the operation and it's confirmed to be only T1A, then no further surgery or chemotherapy is typically required. The problem has likely been solved. But things change dramatically if that cancer has advanced to stage T1B or T2. Here, the tumor has invaded the deeper muscle or connective tissue layers of the gallbladder wall. It is no longer just a surface-level problem. So the treatment has to escalate accordingly. The patient usually needs to go back to the operating room for a much bigger surgery. This involves removing a wedge of the liver where the gallbladder was attached and dissecting nearby lymph nodes to check for any spread. After all that, chemotherapy might still be recommended just to kill any remaining cancer cells. And finally, we come to advanced disease. This is when the cancer has spread extensively to nearby organs, to distant lymph nodes, or even to other parts of the body. And at this point, the goals of treatment have to shift, fundamentally. The source material is very clear on this. Attempting a curative surgery is contraindicated. That means it's not advised because it simply won't cure the cancer, and it could cause more harm than good. Instead, the focus becomes palliative care, relieving symptoms, like using stents to clear up jaundice, and using chemotherapy not to cure, but to control the cancer's growth and improve the patient's quality of life. So as we wrap up, just think about what we've seen. From the chaos of an unexpected surgical injury to the silent progression of an aggressive cancer, the response isn't panic. It's process, it's classification, it's staging, it's evidence-based protocols, which leaves you with one final question to consider. How does medical science create such precise roadmaps to navigate the body's most complex chaos?